Good afternoon, everybody. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome. Health is a product of the world around us, of the conditions where we live, work, and play. Those conditions are in turn shaped by the attention we pay to them, by the resources we dedicate to create the best possible context to produce health. This is why nurturing a conversation that elevates health as a public good is so important, and why it matters for those who are committed to creating a healthier world to be engaged with this conversation. We host these events as a way of doing so as a community, guided by the expertise of our distinguished speakers. Thank you all of you for joining us for today's conversation, and a particular word of thanks to the many who have made today happen. In particular, thank you to Meredith Brown and Alicia Noel for coordinating this event, and thank you to our co-host, WBUR CitySpace. Today's program is part of our Next Normal series. These events are an opportunity to pause and reflect on what we have been through collectively during the pandemic. The hope is that this will help us learn the lessons of the last 20 months so that we might apply them towards shaping a healthier future. The pandemic forced us to adapt to a new normal. As we look to the next normal, we have a chance to ensure that this is radically healthier than our past if we learn the lessons of the COVID moment. One of the lessons of the COVID moment was the centrality of mental health to the overall health of populations. During the pandemic, we saw an increase in poor mental health. This increase was mediated by a range of factors, including exposure to stressors, lack of financial assets, and other socioeconomic forces. Having clarified the role of context in shaping mental health, the pandemic moment should push us to redouble our effort in engaging with this context to improve mental health going forward. We are truly pleased today to welcome panelists who will guide our discussion of how we can do so. Here to moderate our discussion is Lynn Jolliker. Lynn Jolliker is a senior field producer, reporter, and editor at WBUR for All Things Considered. She has developed beats covering mental health and homelessness, and most recently, she has reported on the pandemic's impact on both. Lynn is particularly passionate about reporting on the issue of suicide. In 2015, she produced and reported a 15-part year-long series on the suicide crisis. Prior to working at WBUR, Lynn was a television reporter for 18 years, most recently at Boston's WCB-TV Channel 5. We are grateful to Lynn for her thoughtful coverage and for raising awareness of mental health throughout her work. I'm now really pleased to turn the event over to Lynn Jolliker. Lynn, over to you.
Thank you so much, Dean Galea, and I really appreciate your inviting me to moderate today's very important discussion. Well, we're certainly at a crossroads with mental health. As you mentioned, at the very least, the pandemic has really shined a spotlight on it and brought it into the public conversation. It's being talked about a great deal more, perhaps, and so if anything, that is progress. For more on how we can capitalize on that, we are joined by a distinguished panel. First, we will hear from Dr. Dani Fallon. She is chair of the Department of Mental Health at Johns Hopkins Bloomberg School of Public Health. She studies how environments, behaviors, genetic variation, and epigenetic variation contribute to risk for psychiatric disease, and she has a focus on autism. Next, we'll hear from Dr. Brianna Mezik, who's a psychiatric epidemiologist and directs the Center for Social Epidemiology and Population Health at the University of Michigan School of Public Health. Dr. Mezik's research focuses on the intersections of mental and physical health, including the consequences of depression for medical morbidity and functioning. Third, we will hear from Dr. Courtney Thomas Tobin, who is an assistant professor at University of California, Los Angeles Fielding School of Public Health. Trained as a medical sociologist, she studies the psychophysiological health of Black Americans across the life course, and much of Dr. Thomas Tobin's research focuses on race-based stress and coping experiences in the Black community. And then finally, we'll hear from Dr. Kate Wong, an assistant professor at Yale School of Public Health. Her research broadly focuses on the role of stigma as a psychosocial determinant of mental and behavioral health disparities among diverse, marginalized populations. And I do want to mention before we start the presentations that the audience can submit questions. You can submit questions throughout the event in the Q&A box at the bottom of your screen, and we hope to be able to address as many of your questions as we can later on in the conversation. And Dr. Fallon, I will turn it over to you.
Thank you so much. It's a privilege to be here, and I'm really excited to join the conversation today. I will go ahead and share screen. So, as was already alluded to by Dean Galea and Ms. Jolliker, mental health as a challenge in public health is not new. And prior to the pandemic, as a department chair dedicated to mental health, I would make the argument and remind folks of the importance of mental health in the context of public health already. Depression and anxiety were already high prior to the pandemic. Suicide, as many of you well know, is a leading cause of death in the US, particularly in certain age groups. Many of us feel symptoms of psychological distress, if you will, worried, nervousness, et cetera, on a very frequent basis. And as many of us know, the overdose epidemic has continued to increase. And so this is the context in which we entered the pandemic. I think it's important to also say that when we think about mental illness, there are lifelong challenges associated with this. For the severely mental ill in our society, there is a much higher a chance of early death. And I think it's important to think about the reasons for that. But we also know that experiencing mental illness often doesn't happen in isolation. So we're thinking about a context of folks who have potentially multiple psychiatric conditions or substance use. Importantly, also consequences for physical health, and the synergy between physical health and mental health is a critical component of public health. Other kinds of functional disabilities, and then importantly on here, mental illness has always been associated with discrimination, with social isolation, and often with reduced educational and employment opportunities. And that stigmatization has been a huge barrier to seeking care for folks with mental illness or who are experiencing mental health, poor mental health symptoms. And that's a bummer because mental illness and symptoms are treatable and preventable. And if you leave here today with anything, I want you to keep echoing that these situations are treatable and preventable. We have solutions. Yet often those solutions are not attained and needs are not met. And so the context of moving into the pandemic was, this was already a major public health challenges, already affecting quality of life for many, many folks, yet treatable or even preventable. Needs are not being met, and there's this deep and enduring stigma. And I think that's an important context for then thinking about how the pandemic raised further psychological distress in many of us, and then what that will mean for the next normal. So then along comes the pandemic and many things happening at once. I won't go through this whole list, but all kinds of psychological distress, if you will, that was associated with the virus itself, but also many things that were associated with the public health measures that were necessary to keep us safe, like closures and stay-at-home orders. And then this was happening in real time in the context of other societal challenges, including a contentious election and its aftermath, police violence, and ongoing violence against religion and minority groups more generally. And so that intersection, I think, is important to keep in mind. So early on, we were worried and did see increased evidence of psychological distress and mental illness. And so this was data from the CDC early on showing that about 40% of folks, right after in June of 2020, were struggling with some form of mental health or substance use challenge. And certainly in the substance use side, there are data showing increased overdose death in particular. The top just shows a general rise over the years going from 2015 up to January of this year. And then the bottom shows increases in overdose deaths by state. And I think an important thing to think about is, for whom were these experiences most manifest? And the first answer is in everyone, but in particular, those in emerging adulthood, the 18 to 29-year-old age group, which I think is critical for lots of reasons to know about. And then, as Dean Galea already mentioned, those with financial constraints either due to the pandemic or going into the pandemic. And many others, and I don't have the time to go through all of those, and maybe some of our other panelists will talk about particular groups, but I think it's important to think about not only those that were in financial distress for various reasons, but also those with chronic conditions. So there was good evidence that if you entered the pandemic with either a mental and behavioral health disorder or a physical health challenge or a disability, that the experiences of psychological distress were manifest even greater. And a lot of these folks experienced this kind of distress for the first time, so may not have had the tools or the connections to know how to seek care. Children were particularly vulnerable, although the evidence of that is still emerging. Clearly essential in frontline workers, and I already mentioned emerging adults, but I think it's a really important group because in public mental health, we already pay a lot of attention to this group, which is the first onset often for a lot of psychiatric conditions. And mental health and behavioral health in the pandemic also, brought again into relief the health disparities that exist in our country and many parts of the world. And I just give an example of this one. There are many examples of this. Work with a colleague in our department and at our school, Paul Nestat, had been looking at suicide just in Maryland and saw that in the very early months of the pandemic, suicide rates actually were going down. But if you looked at particular populations, it was in white males, they were going down dramatically, but in Black males, they doubled. And so thinking through particularly affected groups is critical to thinking about how the pandemic is affecting the mental and behavioral health and how we approach a new or next normal. So getting to this next normal, the first thing that I wanted to mention for me personally and as a chair of this department is that I've always known this, but I think in thinking about where we go next, narratives matter, and it's been really critical to see this in the context of the pandemic. Personal connection, either one's own experience or that of a family member or a dear friend, is a powerful tool for destigmatization. And nearly everyone experienced at least some level of psychological distress, some very mild, and some really critical that manifest into illness, and some for the first time. And I have seen that this has changed attitudes. It's changed attitudes amongst leaders, managers, family members, peers, often amongst people who, prior to this, questioned the legitimacy, if you will, of mental health. And now folks are coming together with a new willingness to find solutions. And I think that's a really great opportunity for the next normal. There's also been a renewed sense of purpose for many, and purpose is really connected to wellness and to mental health. The importance of wellness as a concept has also, I think, gotten a lot of new airtime. And as I'll mention on the next slide, I'm particularly interested in employers' amplified interest in this area. And then lastly, a growing realization of the connections between mental health and inclusion, or the reverse, mental illness and acts of racism and discrimination. And more generally, how social determinants of mental health are a critical component of public health. So in terms of actions that I'm thinking of when we think about the next normal, seizing these opportunities of increased awareness and engagement, working with key partners to expand and sustain this opportunity. So working with schools, which is the kind of public reach to many children, working with employers, which is a public reach to adults in our society, but also government, community organizations, and others. And continuing to monitor how our mental health as a population is going is an infrastructural thing that we have to pay attention to, and preparing for this new normal, the next new normal, for the next crisis in ways that we had not been doing prior to this. And as I said, one of my interests is in partnerships, key partnerships. Our department does a lot with schools, but I'm excited that we're also now doing a lot with employers, and many of you and many of the panelists on the discussion today may be thinking about ways that we work with employers. So at Hopkins, we've been thinking about this through a new center that is really focused on worker mental health and workplace mental health. So thank you. It's really a pleasure to be here.
Thank you so much, Dr. Fallon. So much to think about and talk about. And next we will hear from Dr. Brianna Mezik.
All right, I think I've shared the right screen. So again, it's been just an honor to be here today. And I want to really thank Danny for kicking us off with a great overview and some key high points that I think will be reflected in my talk and a lot of some of the other talks later today. So, like, we all lived through or are still living through this pandemic. And I wanted to show you a little bit of acute data about Google searches. So what were we actually Googling during the pandemic? And this is a figure of both Western Europe and the United States. And while we did see increases in searches for things like boredom and loneliness and worry, there were also decreases for searches related to stress, suicide, and divorce. So it sort of wasn't uniformly related. But the good news, of course, was that there for many groups, at least on a macro level, these searches returned to pre-pandemic levels within about 3 weeks of the lockdown orders. And so when this is not the only data that makes me feel this way, but this is one example of data that makes me feel like that while there have been tremendous short-term challenges, there's also been a lot of signs of resilience in mental health, at least at the macro level. I don't mean this to mean in any way that there haven't been and won't be groups that have been disproportionately impacted, but I think it's also, I wanted to kind of start off with at least while there was this acute negative impact, that there's also been some really important signs of resilience. And I think there's really some important opportunities to learn from that as we go forward. But sort of setting the pandemic aside, I want to echo Dr. Fallon's comments that while mental health has likely been more at the forefront of people's conversations around health in the last 18 months, it really has just shown a light on what are long-standing issues and were not a direct result of the pandemic per se. And so I wanted to, in my time today, just review a few of those and then give you some signs or some ideas of what I'd like us to see going forward in terms of the future. So, while for many people outside of the field of public mental health, the term social distancing was a new term that we got in 2020. This terminology is part of public mental health, and it's because it's a term that we use to measure stigma attitudes. And this is just an example of a paper by Anthony Jorm saying that social distance involves the desire to avoid contact with a particular group of people, and it's a core component of stigma. And so when I think about social distancing, that was sort of the first thing that came to my mind. And some groups already had quite a bit of experience with social distancing. Of course, not the kind of social distancing that we are engaging in today, but social distancing as a metric of stigmatization before the pandemic. And that includes people living with a serious mental illness or neurocognitive disorder like Alzheimer's disease or a substance use disorder. People living with a disability, including age-related functional impairments, and people with a history of incarceration are all groups that are disproportionately affected by stigma. Another priority prior to the pandemic, but which I think is going to continue to be a priority, is loneliness. And so the graph here is from a survey that was taken in March 2019 of healthcare leaders, asking them sort of what were their major barriers that they felt their organization needed to take action on in the following year. And you can see that social isolation was up there as one of the top 5. I also want to point out that these other pieces around like transportation, food insecurity, benefits coordination with public assistance, and housing insecurity, these are all social determinants of mental and physical health. And so it's really heartening for me to see that these are being identified by leaders in the healthcare system as issues they want to put at the forefront even before COVID. And certainly the relevance and salience of that is quite evident. Again, echoing Danny's comments, a pre-pandemic priority for our nation and many others is suicide prevention. So while the overall rate of suicide in the year 2020 declined, which was a continuation of a slight decline in 2019, that came off the tail of over 20 years of consistent increase in the rate of suicide in our country. And I really want to, this is a situation where, at least when I give talks about suicide prevention, I will often be met with questions like, can you prevent suicide? And the answer is yes, you can prevent suicide. And we have we have many evidence-based strategies that are really focusing both in immediate suicide crisis, but also far upstream in terms of changing environments, teaching coping and problem-solving skills, and promoting connections, which we know these are factors that are going to have the benefit of promoting and supporting people's mental health. They will also prevent suicide, but in the short term, they have major implications to promote mental well-being. Another pre-pandemic priority, again, as Danny mentioned, is substance abuse and overdose deaths. So in 2020, we have continued to see an increase in the opiate epidemic, overdose epidemic, which has now been going on for about 30 years. And the strategies, yes, we've had some recent policy changes around that have made access to treatment more readily available or easier to pay for. But we have to center this, in my opinion, in terms of how we go forward, because this is a situation that doesn't appear that's going to resolve in any way on its own. So I want to say a couple comments then in terms of, so those are our pre-pandemic priorities, and then I want to switch gears a little bit and talk about the future and what do I think we've learned from this pandemic, and what do I hope are some of the ways that we can change things going forward. So the first is, I think this pandemic provides us a potentially unprecedented opportunity to rethink mental health services. So we know that unmet treatment need for serious mental illness and substance use disorders is substantial. Less than half of the people living with an SMI or SUD get timely treatment for their health conditions. If I told you that less than half the people with cancer or less than half the people with heart disease get timely treatment for their health condition, we would be up like this. We wouldn't stand for it as a society. But this is the truth, that there is really a substantial lack of treatment access, particularly for people with SMI. And what's been interesting is that COVID, when I talk to my partners here in the community here who work in Medicaid and behavioral health services, COVID has sort of revealed that many, or at least some of the barriers that people face getting mental health services are actually created by the system. So for example, in our county, Washtenaw County, our Community Mental Health Center provides a wealth of wraparound services for their clients that are on Medicaid. And these include support getting housing, support with social support, job skill training, et cetera. But those are services that are paid for by Medicaid. And so if you don't have Medicaid, you don't qualify for those types of services. And so the need to pass or pay for these wraparound services that we know are going to help people with living with schizophrenia or bipolar disorder or severe depression, et cetera, to make those types of services accessible to all, I think is going to be really important. We also saw that Medicaid has some very strict reimbursement requirements, for example, around telehealth, and these, of course, have been suspended during the pandemic. But I think it really is going to, the way that telemedicine and the way that we reimburse for these services, I think is going to, there's some really interesting opportunities here, I think, for making access to care more timely and more accessible. And then finally, there's, especially prior to the pandemic, limited access to medically assisted treatment for substance use disorders. And I think there's been increasing evidence that this, the system doesn't have to be this way, that we can make changes that are not only going to benefit the patient or the person who's receiving care, but are likely going to be cost efficient and cost effective long term. Another thing I think that I'd like us to focus on in the future is valuing the mental health of older adults. So COVID mortality had some of its largest impact on the residents and staff of long-term care facilities. You may remember that this is the first outbreak that occurred in our country occurred in a nursing home, a set of nursing homes in Washington state. They've determined that part of that outbreak was caused by staff that were working at multiple different facilities that basically transmitted the virus with them as they were working in different places. They also showed that the CDC report showed that these staff were undertrained, that they were overworked, and this, as is the case there, this is an underpaid job. And so it's really important that I think that these individuals who are, and when I say residential care facilities, I mean everything from sort of independent living to assisted living to nursing home or memory care. And so I really hope that COVID will allow us to sort of collectively rethink residential care and renew support, including financial support for policies that support aging in place, because we know that aging-friendly communities and neighborhoods are communities that we all benefit from living in. I want to echo Danny's comments about work. Work is therapeutic. It provides for a lot of us a source of purpose and opportunity to connect with people and learn. However, job strain and burnout are really important contributors to poor mental health. And I'm happy to see the work that the Department of Mental Health is doing in collaborating with employers. I also wanted to point out that COVID has accelerated early and often unexpected retirements among older workers, and these types of unexpected retirement transitions are generally associated with worse mental health. And so while we don't know what this is going to look like yet going into the future, I am sort of concerned that older adults' mental health needs we sort of need to consider what sorts of resources and supports we need to provide for that. I also think, sort of along the line with supporting mental health of older adults, that we need to center the mental health needs of caregivers. And by that, I mean both formal caregivers or members of our healthcare professionals, but also informal caregivers. And I mean that whether that's as a parent of a young child or children of aging parents. And we stand out as one of the few nations that does not provide paid sick leave and has, while there are examples of programs like flexible work and employee assistance programs, these are not accessible to all types of workers. And I think we really need to, expand access to those and financial support for these initiatives. The other sort of piece I'd like to leave you with is that mental health is health. And by that, I mean, it is integral to, we don't have, we all have a neck, right? So they're above the neck and below. But conditions like serious mental illness and conditions like depression and anxiety impact both the risk and management of chronic physical health conditions like diabetes, heart disease, cancer, et cetera. And we have strong evidence-based models, such as the collaborative care model, that are clinically and they're clinically effective, they're cost-effective interventions that improve both mental health and physical health simultaneously. However, uptake of these approaches to care remains limited due to reimbursement challenges from payers. And so I hope that we don't need to invent a solution to this problem. We actually have a very good solution to this problem. But what we need are incentives to align so this access to this collaborative team approach to care can be accessible to all. This is I think my penultimate slide. So public mental health is really a multi-sector field. It is not the job of any one sector to support public mental health, but it really does. All different sectors, lots of different sectors have a place at the table. And so I encourage everyone who's sort of, attending today, if you see yourself sort of represented somewhere on this chart, to sort of consider or reflect on the role that your sector may play in being able to promote mental health in our country. And I will close here again with just my take-home message from today is that there is no health without mental health. And I encourage you to connect either with me either online or through Twitter. So thank you.
Thank you so much, Dr. Mezik. And now we will turn it over to Dr. Courtney Thomas-Tobin.
All right, can everyone see my slides okay? Great. All right, well, good afternoon, everyone. I'm really excited to be here and to be a part of this really important conversation with my fellow panelists. So I've primarily viewed many of the issues that my previous panelists have discussed today through my lens as a social stress researcher and also as someone who focuses on the health of the Black American population. So today I'd like to add to our conversation and perhaps contextualize it in some ways by spotlighting the impact of the pandemic on the mental health of Black Americans. So as many folks well know by this point, Black Americans have been disproportionately impacted by the COVID-19 pandemic based on several metrics. And as we can see here, as highlighted by the red box, relative to non-Hispanic whites, Black individuals experience higher rates of COVID cases, hospitalization rates, and COVID-related complications. And so thinking about the mental health challenges faced by this population, estimates also indicate that while rates of more generalized distress symptoms like anxiety or depressive symptoms may be similarly high among Black Americans relative to other groups, it's high among everyone. This population is experiencing elevated rates of trauma and stress-related disorders, suicide ideation, and new and increased substance use, specifically related to COVID and pandemic-related stressors. So although African Americans only make up about 12 or 13% of the US population, not only are they overrepresented among COVID cases and deaths, but these findings demonstrate that they're also experiencing major mental health challenges directly attributed to the pandemic. So why do we see this? Like Bree and Danny mentioned before her, we have scholars in many ways have recognized that the current situation for Black Americans is what some term as a pandemic on a pandemic due to the synergistic effects of both COVID-19 and systemic racism, and particularly, a great deal of civil unrest and greater recognition of police brutality and systemic inequalities. And so in many ways, we recognize how these issues are intertwined and the challenges faced by Black Americans, through the criminal justice system, through mass incarceration, police brutality, all also relate to medical mistrust and challenges with interacting with the healthcare system. So it just continues to exacerbate many of the issues that we saw pre-pandemic. Including, but not limited to, some of these other issues like health comorbidities, health challenges, quality and access issues with healthcare, work and financial resources. We know that Black folks continue to be overrepresented in many of the lowest paying service positions, essential worker positions. And so thinking about the precarious nature of these positions on top of, having additional physical health comorbidities and challenges, it just continues to make these challenges worse. Add that to issues with residential segregation, housing, incarceration rates, and long-term care facilities. When we think about all of these things together, it just really, again, exacerbates some of the additional risks that Black Americans face. And so those are things that were challenges pre-pandemic. But as we think about kind of what are some of the challenges that contribute to these heightened rates of mental health challenges. And so, as I mentioned before, we know that many African Americans are employed in these more precarious employment positions. And so, unemployment surged for everyone. And we know that rates were particularly high for African Americans. Add that with the many education and school-based disparities. On the one hand, we can think about systemic or system-wide challenges with differential allocation of funding and different resources, the technology gap, but then just the added challenge of parenting that many folks faced during the pandemic. These stressors became heightened for Black Americans. Same with food insecurity, and one that is not often or is not as often discussed as some of the financial challenges is recognizing the toll of death and bereavement. Given the broader impact and the high death rates among Black Americans, it should come as no surprise that death and bereavement is a major byproduct or consequence of this pandemic, and recognizing the stress and trauma of loss, is, it's really important for us to keep in mind and to think about, so more so than the tangible loss of goods and resources, the unexpected and sudden loss of life among this population is an additional stressor that only continues to make this mental health challenges worse. And so then coming full circle, thinking about how these different issues constitute even greater stress. And when we oftentimes think of the many challenges faced by the pandemic, it becomes very, easy to think about kind of the tangible things. And so what I want to highlight as part of our conversation is thinking about kind of the specific subgroups among Black Americans, and thinking about how these groups may face additional risk and challenges, particularly when we think about pregnant women, among whom Black women already face this heightened mortality risk. And so adding that to the additional stress and burdens of the pandemic contribute to heightened feelings of vulnerability among this population. And then added to that, we think about kind of the long-lasting impact on young children. And so, I highlighted many of the risk factors and the challenges that we face, but what can we do? As we try to think about how do we move on from this step, we've been in the pandemic this long now. And so what are some of the lessons that we can learn from these various challenges? And so first and foremost, I would say is, to address many of these negative impacts of the pandemic, including those that I just highlighted, our social determinants of health that we recognize as serious barriers to health equity. But then we also really need to recognize the pandemic and its effects as the traumatic experience that it is. While many folks have certainly demonstrated resilience, it's important to remember that resilience is not without its costs. And for Black Americans who are already facing so many challenges pre-pandemic, trying to get back to our next normal is uncharted territory in many ways. And so from a public health standpoint, it's essential that we first recognize and acknowledge this experience as trauma so that we can approach this in a more effective way. So I want to highlight just two opportunities that we might use to reach our new normal in this population. So in much of my work, I emphasize the role of protective factors. And, there's a great deal of work on the mental health significance of the Black church. And many folks think about the significance of the Black church in shaping public health perceptions, health behaviors, and providing a connection to communities and also through communities. And so thinking about the ways that public health professionals in various sectors can partner with churches, which represent these centers for public health advocacy. There's a lot of really great programs going on right now. In addition to, COVID vaccine drives and other strategies to address kind of community-based needs. There's a growing recognition of the need for mental health advocates within church communities that have really been making some great strides on the ground. And then also thinking about the power of social media, which is far from new, but like many other aspects of our lives, the pandemic has really demonstrated some great opportunities for this form of communication. And a recent study by Ottlieb and colleagues really highlighted the role of Black Twitter and the ways that users use various forms of humor and expression to form these really interesting ways of coping and connecting with others, providing awareness with different mental health resources and opportunities. And so going forward, it's really up to us to develop some of these creative ways to engage with communities and meet folks where they are to really utilize these various strategies. So I'll stop there. Thank you.
Thank you very much, Dr. Thomas Tobin. And next we'll hear from Dr. Katie Wong.
Great, thank you. Good afternoon, everyone. It's a pleasure for me to be here. So as we have heard from other panelists, the COVID-19 pandemic has taken a significant mental health toll for everyone, but it has disproportionately impacted socially marginalized populations, such as Black Americans and people with disabilities. So in my presentation today, I would like to spotlight the pandemic's mental health implications for people with disabilities, who at nearly 25% of the US population represent one of the largest minority groups in our country. Apologies, I'm just trying to find my slide here. Sorry about that, here we go. So as a result of both interpersonal and systemic forms of ableism, people with disabilities have faced a number of unique challenges and stressors since the start of the COVID-19 pandemic. So just to give you a couple of examples, during the start of the pandemic, many people with disabilities had difficulties obtaining basic supplies such as groceries and medications because the delivery services that people with disabilities typically relied on became extremely unreliable and in many instances were not available at all. At the same time, individuals who required assistance with daily living activities were also struggling because many personal care assistants stopped working due to concerns about COVID risk and the expectations that we should all maintain physical distancing from people who live in different households. In addition, as the healthcare system became overwhelmed by the number of COVID patients who required hospitalization and intensive care, medical rationing has emerged as a huge concern for the disability community. Many doctors tend to conflate disability with quality of life, so they might assume that a disabled patient does not have a good quality of life. And this assumption can make it less likely for patients with disabilities to receive adequate care when healthcare resources are constrained. And as one final example, given that people with disabilities tended to have smaller social support networks and they were twice as likely to be in poverty compared with their non-disabled peers, even prior to the start of the pandemic, they are likely to end up in a particularly precarious position when facing the pandemic's pervasive social and economic impacts. Given these challenges, it is not surprising that the pandemic has taken a particularly heavy toll on the mental health of people with disabilities. So according to a large national survey in the UK from March 2020, so at the very start of the pandemic, people with disabilities reported more than double the rate of self-harm or suicidal thoughts and more than triple the rate of self-harm behaviors compared to those without disabilities. It is important to acknowledge, however, that the disability community is highly heterogeneous with a wide range of lived experiences and support needs, and the pandemic does not affect all people with disabilities equally. So to address this diversity within the disability community, I want to share with you some data that I've been collecting in my lab over the past year or so. And this data highlights some of the demographic and psychosocial predictors of depression and anxiety symptoms among US adults with disabilities during the COVID-19 pandemic. So we conducted a survey between October and December 2020, and we recruited participants from disability-focused social media platforms and email listservs. A total of 441 adults living in the United States who self-identified as having a disability participated in our survey online. Participants completed a series of self-report questionnaires, including measures of depression and anxiety symptoms, measures of disability-related stigma, social isolation, pandemic-related stressors, such as how worried they are about contracting COVID, either for themselves or for their family members or close friends. And we also have then completed measures of demographic and disability attributes, which we included as covariates in our analyses. So overall, our participants reported very high levels of psychological distress. We had 61% of our participants met diagnostic criteria for probable major depressive disorder, and we had 50% of our sample who met diagnostic criteria for probable generalized anxiety disorder. Our participants also reported significantly higher levels of disability-related stigma and social isolation compared with pre-pandemic norms that were established in prior research that have been published. So we ran 2 regression models looking at potential predictors of depression and anxiety symptoms. So here's a snapshot of our results for depression with significant predictors highlighted in yellow. So as you can see here, significant predictors of depression symptoms include higher physical pain, lower energy levels, younger age, having a pre-pandemic mental health condition, being Hispanic or Latinx, being cisgender, having higher levels of worries about COVID, lack of basic supplies such as medications and groceries, having higher levels of disability-related stigma, and higher levels of social isolation. Here are the results with respect to anxiety symptoms. So the pattern of findings here is generally pretty similar to what we found for depression, with only a few exceptions. So in this model, having multiple versus a single disability was associated with higher anxiety symptoms. And some of the demographic and disability covariates, such as energy levels and ethnicity, were not significant. There is something rather surprising about these findings I want to quickly acknowledge here before I move forward. And that is in this particular sample, being transgender or gender non-binary was actually protective of mental health. So this finding clearly contradicts prior research, which shows that transgender and gender non-binary individuals are at increased risk for mental health problems due to stigma and marginalization, both in general and also specifically during the COVID-19 pandemic. So we don't really know why this discrepancy happened. So it will be really important for future research to further explore the unique sources of risk and resilience for people with disabilities who also identify as gender minorities. So based on these results, I want to leave you with a few take-home messages and recommendations in terms of how we should better support people with disabilities as we navigate this next normal and also prepare for future public health crises. So first of all, our analysis suggests that disability-related stigma, social isolation, and worries about COVID can exacerbate mental health risk for people with disabilities during the pandemic. So What these results suggest is that there is a lot of value in virtual communities and support groups that connect people with disabilities with one another. These groups can mitigate social isolation, especially during a pandemic, but they can also facilitate stigma coping by providing a sense of solidarity. In addition, educating healthcare providers about implicit and explicit forms of ableism will help combat the pervasiveness of disability-related stigma in healthcare settings. So this might also alleviate some of disabled people's worries about contracting COVID-19, which are in part driven by the fear that they would not be able to receive equitable treatment if they were to get sick. Lastly, it is important for policymakers to ensure that public health measures to prevent the spread of COVID-19 are accessible to people with disabilities. For example, efforts should be made to increase the accessibility of COVID testing and vaccine sites. So when the COVID-19 vaccines were first launched, there were a lot of issues in terms of accessing vaccine appointments for people who are blind because the websites used for vaccine appointments were not accessible with screen reading software. There were also a lot of issues in terms of people being able to get to their vaccine appointments because they did not have access to transportation. So policymakers should really be brainstorming about ways to provide assistance and support to people with disabilities to help those who need additional support with accessing these important public health services. Our findings also suggest that people with disabilities who have more support needs, such as those with multiple disabilities, individuals with pre-pandemic mental health conditions, or individuals with chronic pain are at elevated risk in terms of their mental health during the pandemic. So these findings really highlight the importance of targeted interventions to ensure that individuals who are particularly vulnerable receive the support and services they need. Possible strategies that might help in this area can include things like psychotherapy via telehealth, home visits from healthcare professionals such as nurses or physical therapists, home delivery of medications or groceries, and also assistance with daily living activities. So I just want to close out by quickly acknowledging my collaborators on this study, as well as the funding source for this data collection. I also just want to thank my fellow panelists for this wonderful conversation. And thanks so much, everyone.
Thank you very much, Dr. Wong, and all of the panelists for those great presentations. So we are going to have questions now, and I'm sure we could easily talk all evening about this. Again, audience members, you can submit questions in the Q&A box at the bottom of your screen. I have some questions as well, so I encourage the panelists, if we can just keep things moving as much as possible, we'll get to as many questions as possible. I would love to start by just asking a little bit more about the idea of human connection and isolation versus isolation in all of this. And if there's a kind of lack of big thinking on this. You know, we hear so much about mental health care, the lack of, enough beds. We don't have enough beds. There's always a shortage. There are not enough providers. We don't hear enough about, I don't think, it doesn't seem like we hear much about the other end of things, the prevention and awareness and simple things. I mean, what can be as simple as human connection and empathy and support as a prevention tool in mental health and suicide prevention. So I'm wondering who would like to comment on that, and should we be seeing more investment in awareness programming and even such things as peer support programs, which are growing, but people in that community who work in that community say, this is proven to work. We don't see enough of this. We hear a lot about treatments and medications, not enough about human connection and support. I'll throw it out to any of you.
I mean, I guess I would just briefly comment. I think, oftentimes when people think about suicide prevention, they think about, like suicide hotline number. And that's like saying that we would prevent deaths from heart attacks by, through bypass surgery. I mean, it has to be far more upstream from that. And, providing meaningful social interactions and also making it, that people have connections where they can get help if they need it. It's not that your friend group is no substitution for a trained, therapist, if that's, who would be helpful for you to talk to. But, I completely agree that, at least when it comes to suicide prevention, there are things that we could be doing that make it true prevention rather than crisis intervention.
I'd like to
I'm sorry, go ahead.
I was just going to add on to that. I think a lot of it does have to do with kind of our approach from a top-down approach, which, we definitely need to invest in policy and infrastructure in the healthcare system. But like Bree just mentioned, thinking about this again from a preventative standpoint, there are so many things that we can do on the ground level to increase awareness and to really improve connections, more so than thinking about it as like, make friends with each other, like thinking about it as a legitimate public health effort can really go a long way. And yeah.
Yeah, I was interested, Dr. Mezik, when you mentioned healthcare leaders in that poll saying that they would be, I think 19% saying they would be doing more on the social isolation front. So I would be interested to know what they can do. Is it screening their patients for isolation as people are screened now for signs of depression?
I'm hesitant to say that that's the way we should, that should be the main pathway. I certainly think I think it's great that there's more connection between healthcare systems and social services and community needs. And this is, to Courtney's point, and we've had community health workers and promodoras for a long, long time who've been doing this exact thing because the healthcare system has failed to actually meet people's community needs or meet them in their community or even know the community that they're from. So I think there have been a lot of grassroots sort of creations there. I think that the healthcare system as it exists now is not set up to necessarily be the thing that changes that, but perhaps those healthcare leaders were speaking more about social isolation around their employees, right? The people that, often, University of Michigan has, thousands and thousands of employees, for example, in our healthcare system. And so I think to Daphne's point, I think the workplaces are really like ground zero for doing some of these prevention and health promotion efforts.
Great. I'm going to take a question from the audience asking, what do we know about the relative effectiveness of mental health care services provided remotely versus in-person services? And I would like to tack on, what is the future of telehealth? We saw an explosion of it in the pandemic. Some people say it's the answer to giving people more access to mental health care. Not everyone can access it. People have issues with with access to technology. And then there's the question of long-term, payment. Is this going to be paid for in the same way as other care? So what place is it going to play, and what do we know about the effectiveness of talking to someone over a screen versus in person?
I can start a little bit and then let others jump in. So as you said, there was this wonderfully rapid relaxation of some of the rules around telemental health in particular during the pandemic. And, some of the traditional hesitations in mental health specifically have been that there are a lot of nonverbal signs, body language signs, other things that really are part of the evaluation and treatment relationship. And clinicians really concerned that you wouldn't get the benefit of those things through a telemental health visit. And I think there's been a lot of anecdotal discussion about this and some evidence building, but this was happening in such a critical moment that there wasn't a lot of embedded evaluation as the gates opened, right? So I don't know that we have a great evidence base to say how much those concerns were validated versus proven to be, maybe inflated. But some anecdotal evidence would say that they were able to accomplish more than they expected they would be able to, clinicians would say, than they expected to accomplish, but that there were still some, limitations. But the flip side is no-show rates went way down, I think, across a lot of people's experiences. So that's a good thing, right? you do have to worry about the access part, but I think the access part goes both ways. Technology might not be enabled for particular populations, but it certainly did open doors for folks who had not had that access previously. So my assessment from colleagues here has been that the jury's still out, and we needed to continue this evidence base to be able to answer a question like yours with more actual data. But there's good reason to believe there are some promises. And so that evidence is what will drive that future policy. And so until we have really good evidence to articulate to guidelines and to reimbursement, we won't know for sure where this is going to go.
Thank you, Dr. Fallon. Another question from the audience. Catherine is asking Dr. Thomas Tobin, I have seen an uptick in Black public figures talking about mental health issues they or loved ones have faced. Do you see this type of exposure impacting the stigma and or willingness of those in the Black community to seek treatment? If not, how do you think we can support these individuals better?
What a great question. And I would say, yes, I do think it's really having a positive influence, just, you know, in the simple fact of just starting a conversation for particular segments of the Black population. That could be very important. You know, as I mentioned with social media, there's, you know, lots and lots of threads on Black Twitter and on even TikTok with young folks really being vocal and upfront about the mental health challenges that they're facing, encouraging each other to, you know, seek help, talk to a counselor. They're sharing resources. And so, you know, we're really seeing this kind of mobilization around mental health among the Black population that I think we have not seen before. I wouldn't say that that necessarily, you know, encapsulates, you know, all age groups, for example, or, you know, folks in all, you know, communities or locales. But I do think that there's definitely more of a kind of mainstream conversation that's going on that I think is really important and very valuable.
Thank you. And I think my connection might be a little unstable. Hopefully it's okay right now. Holler, everybody, if you're not hearing me okay, or if I'm freezing up. That brings up another question I wanted to ask you, Dr. Thomas Tobin. In terms of access, we know there's a critical shortage of, you know, providers across the board, but particularly providers of color. And you know, if we want more people to seek help, seek care, what we hear from a lot of people is, well, I don't see providers who look like me or who understand my lived experience. And do you see the needle moving on that? You know, we know that the communities of color have been hit harder than other communities in the pandemic. Will that translate into more movement in terms of doing things to attract more people of color and compensate them? This comes back to reimbursement rates as well. I mean, it's all such a sort of vicious cycle, I guess. But what would you say to that in terms of just the need for more providers of color and whether you see any dramatic change on that front?
Dramatic, I would say no, unfortunately. You know, it's one of those where I think the needle is moving, but very, very slightly. Again, I think it kind of fits in with some of the things we were talking about previously, where, you know, I've seen more and more like community-based resources, more like, you know, lay mental health advocates or like support groups and kind of grassroots efforts. But I couldn't say that I've seen evidence of like a increase of, you know, like medical professionals, psychiatric professionals, no. And so that is definitely one place that, you know, of many that we really need to increase our focus, because again, if we want to encourage folks to seek help and to reach out, then it's important to have people who look like them, because that makes a big difference in terms of, you know, kind of increasing access, sharing connections with the community, but then also, you know, given, you know, the significance of racism within the healthcare system, and just within the lived experiences of, you know, many Black folks, it's just, you know, if you want to, you know, share your experiences about racism, you don't necessarily feel comfortable sharing that with somebody who doesn't have those similar experiences.
Thank you. We have lots of great questions coming in the Q&A. We'll get to some more of those. Dr. Wong, I have a question for you, and I'm sure others could address it as well. I think I'd like to, keep things moving as possible, but actually about language. And, a lot of people say we won't make progress, I guess, or arrive at a new and better normal if we don't improve the way we talk about these things in general. I want to ask about the word stigma, actually. I've found that when I do reporting stories on mental health that include the word stigma, even when someone else is saying it, not me, I oftentimes hear from someone saying, we shouldn't use that word. Continuing to use that word continues to perpetuate and create stigma. And I've done a little more reading about this and read some things, opinion type pieces where people say that it's actually discrimination. And what we should use is the term discrimination, people facing discrimination in housing and healthcare. That's what it is. And let's not keep using this word stigma. So I'm curious about that. Do we get stuck in it by continuing to use that term?
That's an excellent question. So as someone who studies different aspects of stigma, prejudice, and discrimination, that's something I've definitely wrestled with in my own research. And what I would say is that I consider stigma to be a broader construct than discrimination. So someone faces discrimination when they encounter unfair treatment in housing, in employment, and so on and so forth. But stigma can impact people even when there's no actual discrimination taking place, right? So if someone has encountered a lot of discrimination in their past based on their race or their disability or what have you, they might internalize that negative experience. They might believe that they are not deserving of good things that could potentially happen to them. They might be hypervigilant as they enter a new situation, as they interact with new people. They might be very anxious in terms of how they will be treated. And those internal or psychological experiences are not captured by the term discrimination. So that's why personally, I continue to use the word stigma, is to capture the multifaceted experience of social devaluation and discrimination and marginalization that a lot of different populations are facing in their day-to-day lives.
Thank you. Such an interesting point to think about. Another question from the audience, and I'm not sure, perhaps Dr. Mezik or Dr. Fallon, in terms of substance use, someone's asking about substance use disorder units. I've heard a lot lately about, and this is from Rob, I've heard a lot lately about the need to create 24/7 mental health SUD or substance use disorder crisis stabilization units. What do you think of such programs? Is there empirical evidence of their efficacy? What do you think is the best path for stakeholders to take toward opening them?
So yeah, any other panelists could probably answer this better than I. But so these are units that are sort of like 24/7 urgent care facilities focused on mental and behavioral health. And often they are where first responders may be able to take someone rather than an emergency department. And you can see where then you're taking it to a place where there's expertise able to handle someone in crisis like that. And often these stabilization units are able to stabilize someone and get them back into the community faster than if you take them to an ED and then they get admitted to a psychiatric inpatient facility, for example. So as far as I know, and this is not my area of research, there's some good evidence for cost effectiveness of this, but who benefits in that cost is sometimes part of the barrier to then expanding this more broadly. So I don't have a great answer for then how stakeholders could push that agenda further, but I do think there are mental health policy researchers who have more insight into that part of it.
Yeah, I would just briefly, I agree. I am not as familiar with the specific units described in the question, but what this question raises for me is, again, the need for interprofessional collaboration. So, the first responder to an overdose is usually a police officer, or the first responder to a mental health crisis is often a police officer. And, yes, there is a need to train officers on how to respond appropriately, but I would love to be able to see crisis response units where somebody who doesn't have a weapon is showing up at a crisis, so we can help get someone. Again, this is again though that like this is not prevention. this is that treating the heart attack. But we really need a very different response to crisis than what we have now.
Thank you. We have a question about reimbursement, the very important, huge issue of reimbursement. Jason is asking, can Dr. Mezik or any of the panelists speak to any specific efforts that are ongoing to improve reimbursement policies for existing collaborative mental health care models?
So I can only say, like, you got to follow the money. Like, that's all of my work that I talk about with, or when I talk with mental health advocates or people working in behavioral health, it really comes down to who is paying for what and how much. One of the things, I can't speak to this question specifically about collaborative care, but I will say very briefly that when because of COVID, one of the things that changed, at least in our state in Michigan, was that you no longer needed to have a 15-minute call with a person on Medicaid to get fully reimbursed for a touch point with that person. And so prior to COVID, you needed to have someone on the phone for a full 15 minutes. And so this Trish Cortez, who runs our community mental health board here, was telling me that they were able to really help people get stably housed and stay in contact with people who have severe mental illness in a way that they hadn't before, because they could just have a quick phone call of a few minutes, because oftentimes people who don't have a lot of financial resources, they're not on a unlimited minute plan. And so, just even something little like that, in this case was really, they saw have a measurable impact on getting people who had serious mental illness stably housed during the pandemic.
Great, thank you. I think we have time for one more if we can handle it quickly. Wow, time has flown. Dr. Wong, in your opinion, this is from Courtney in the audience, how can we increase in-home accessibility of resources to those with disabilities like technology, internet, telehealth, nutritional services, access to online support, etc.?
Right. So I think a lot of it really comes down to policy and thinking about how to, for the government to think about how to support people with disabilities in their homes, right? So at the start of the pandemic, as I recall, there were a lot of conversation about people who are on food stamps and how grocery deliveries were not covered by food stamps in a lot of states. And that was obviously hugely problematic for a lot of people because, it was dangerous to go out into the grocery store and it was dangerous to use public transit. So for low-income people with disabilities, they had a lot of trouble getting things like groceries delivered because they were not covered by food stamps. So there were a lot of advocacy efforts with regard to that. And I think in the matter of a month or so, a legislation was passed that allowed food stamps to cover deliveries in most states. So I think that was just one example. I think other examples could be, like providing free or low cost internet to people with disabilities who are low income, or providing things like telehealth and just continuing to reimburse that either for Medicaid or Medicare and for other insurance going forward, so that again, people who have difficulty accessing transportation can still access those services.
Well, the time has already arrived and we need to wrap. Thank you so much to the panelists. And I'm sorry to those in the audience whose questions we weren't able to get to. Lots of great questions. And thanks so much again, Dr. Galea, for having me.
And thank you very much, Lynn, for excellent moderation. There was a comment in one of the Q&As where one of the questioners said this was an essential webinar. I really couldn't think of a better way of putting it. I thought the webinar rose to the level of challenge that we posed to it, which is what is the next normal and how do we think about mental health going forward? I'm deeply grateful to all the presenters, Lynn, to you for moderating, and to the audience. I feel like these conversations are better with an engaged audience, and we had a tremendously engaged audience today. So everybody, thank you. Thank you for being part of the conversation. Thank you for everything you do. Everybody stay well, take good care.
Thank you all.